Welcome, everyone. So glad to have you. This is actually our first Autism Consortium meeting of the spring, fall semester. So great to have everyone. Just for those who haven't never attended this event, we do them once a month. And this month, the dates are kind of different depending on when speakers were available. But I think next semester, so that's this semester, but in spring semester, we're going to try to make it a regular day and time and probably work with Meredith's Developmental Behavioral Pediatric office too on coordinating some of the talks. So that'll be, we'll get more consistent and it'll be easier for people to, put it on their schedule. So yeah, I think that I just want to let people know we do these once a month. The Autism Consortium started a few years ago just as a way to bring anybody together who's on campus, who's in the community, students, faculty, professionals together who are interested in learning more about autism research and autism practice. And so we're going to talk about that today, and Kate will introduce our speaker, Meredith Brinster.
Great, thanks, Sandy. So first of all, I just want to let everyone know that next month, to put on your calendar, our October speaker will be Dr. Sandra Venegas, and she'll be presenting on Monday, October 17th at 2 p.m. And some notices will start going out about that starting next week. So keep an eye on your email and on our social media for more information on registering for that. So Dr. Meredith Brinster is an assistant professor in the Department of Psychiatry and Behavioral Sciences and is a psychologist in UT Health Austin Pediatric Psychiatry at Dell Children's Developmental Behavioral Pediatrics. She specializes in treating children, adolescents, and adults with a range of developmental, behavioral, emotional, and academic concerns, including autism, attention deficit hyperactivity disorder, learning disabilities, anxiety, and mood disorders. And she's also a discipline coordinator in our ACLEN program. And we are so glad that she is able to join us today. So I will hand this over to Dr. Brinster. You're muted. Okay, it sounds like Dr. Brinster is having some problems with her audio. Her mic's not picking up. I can't hear you at all.
Yeah, it's funny because we could hear her before.
Right.
Okay, here we go. It said pause audio share. How do you hear me now? Okay. Can we still see it?
Yes.
Okay.
Yeah.
It changed something when I started sharing. Let's see if this still works. Okay. Does everybody hear me? Can they see the screen? Are we good? Okay. Excellent. Okay, well, I'm just going to finally get started here. I'm so sorry for all these technical difficulties, but I'm excited to be here and just talk to you all about the stuff broadly, really the services, the training, the research, everything that goes on in our Developmental Behavioral Pediatrics Clinic. I think the last time I presented to the Autism Consortium was several years ago, so we've had quite a few changes in terms of expansion in staff, in services, and a lot of things, including, of course, getting to be a part of this wonderful LEN training program. So that's sort of the broad overview of kind of why I'm here today. Quickly, I'm lucky to have these wonderful affiliations. As Kate mentioned, I'm part of Dell Med in Psychiatry Behavioral Sciences, but I'm clinically embedded in our Developmental Behavioral Pediatrics group through Dell Children's. I'm part of our comprehensive autism program, which is our interdisciplinary assessment team that we'll talk about. I am now one of the official trainees for the LEN program. I currently serve as one of the board members for the Autism Society of Texas. And now that I've got a little kindergartner, I'm part of the Austin AISD PTA for St. Elmo Elementary School down here, which is really fun. It's a very diverse school, and it's been fun to kind of integrate with the community that way. I moonlight also as a parent, and these are my little kiddos. So in terms of development, I love to watch them grow and study it from my own house sometimes. So I like to give them a little plug. And this is my daughter on the left here, who sometimes likes to come in and help us out in our trainings. And she's got all her gear on there. So we'll give them a little shout out. The objectives today is really just to describe clinical support services that we provide through DBP, as well as the ages served. As this has sort of changed over time. Mostly we've been expanding the age in which we would, we'll continue to see new patients and track some of our existing patients. Definitely want you all to be able to evaluate the impact that we have on our novel service delivery models, and some of the research I'll briefly touch on the agenda that we have as our research group. I definitely want everyone to know how to recommend families and patients to DBP for appropriate services. So we'll talk a little bit about that, talk about what are appropriate referrals, and then really kind of practically how would that take place. And then also for anybody interested, I hope people will understand how they might participate or collaborate with any of our current or future endeavors through DBP, whether that's collaborations with other disciplines as a trainee, as research. So hopefully this will help to kind of give those in the community and different fields a sense of what we're doing and how maybe we can collaborate or continue to serve the community. So overview, we're definitely going to go through patient demographics. We'll talk about our team, assessment services, our intervention services, some of the community outreach and partnerships, and then we'll finish on briefly touching base about our research, the referral process, as I mentioned, and then leave space for questions. That being said, please feel free to either raise a hand or put a question in the chat. At the end, I can circle back to the actual the chat and walk through those if we want to, but please feel free, or any of the hosts can help me jump in if there seems to be a question that I can clarify along the way. This I actually pulled from our website. We recently updated that just to be a little formalized in our community presence. So this is our mission and our core values. So we want to provide highest quality, evidence-based medical and community-based care for children with neurodiverse and behavioral needs in Central Texas. So, and also a big part of our goal is to really improve access to services, addressing inequities in healthcare. And then one of the ways we really feel like we can do that is the innovative care models, research, of course, and then training the future of providers who may want to stick with the field and help serve the community. Let's see, so we'll jump right in here. So the demographics that we see, we sort of technically at this point will take new patients ages 0 to 15 at this point. And so I have this little histogram over there to the right to show you that the majority of our patients are on the younger end of the age spectrum, but that and fewer and fewer are at the higher end. But we anticipate that our current patients are sort of going to grow into those older age ranges. But at this point, we really are one of the subspecialties that are equipped to evaluate some of those really early developmental milestones. And for that reason, some of the primary referral concerns we have are speech delay, behavior challenges, concerns about attention or increased activity level, global developmental delays. So sometimes, they'll have a child come in that has kind of delays across the board, including motor and then speech. And so we're really there to help parents understand that, and, within the context of their broader development. And then some social difficulties. So sometimes we may hear that a child maybe doesn't integrate as much with peers, or that social difficulties can sometimes come across from teachers or daycare providers. It's unfortunately not too uncommon for a child to have some difficulty attending certain daycare or childcare settings because of behavior, and sometimes that will spur the evaluation process. Typically, some of the main diagnostic considerations that we see are autism spectrum disorder, ADHD, global delays or intellectual disability, specific language impairments, and anxiety. And as we all know, and what I like to share here with this image is that it's a pretty complex, hypothesis testing and a lot of overlapping symptoms among many of these different diagnostic categories. So it's something that we definitely keep in mind and try to tease apart sort of what feels like the most appropriate and helpful conclusion, profession, or impression, plan, or even diagnosis. In addition, I always like to point out that there are really common complexities that kiddos come in with, even in the face of sort of those specific referral concerns. A pretty high majority of our, a high number, not majority, but a number of our patients experience some or multiple of these complicating factors. So it could be premature birth or even just low birth weight, utero exposure to drugs, alcohol, all sorts of things. There could be co-occurring hearing impairment. There could be disrupted attachment, meaning that caregivers might have changed early on. Of course, any variety of socioeconomic challenges we like to keep in mind, particularly when we're making those referrals and understanding kind of what is feasible for a family. English as a second language is a big consideration. And then a subset of our kiddos do come to us perhaps with some known genetic variants, or may kind of come to understand that's part of their child's picture down the road through different referrals and specialists that they may see after coming to DBP. Let's see. So here's our team, and it's kind of exciting to share because, like I said, we are growing, and this is something that we hope to continue to grow. But our medical providers include our section chief, Sherry Ravenscroft. We also have a developmental behavioral pediatrician who is up in Cedar Park, Dr. Tran. We have another pediatrician, developmental pediatrician, who joined us even more recently, Natalie Serta, and she is Spanish speaking. She provides services both at our Capitol Plaza, more central location, as well as some down in Buda. And then Cordelia Garcia is our nurse practitioner that's been with us for the past 4 or so years, who does provide both new patient appointments as well as a lot of medical follow-ups. And let's see, so then we have the psychology assessment team, which is led by myself and our lovely psychometrists who, for those who are not familiar with that term, they are sort of like a technician for delivering standardized tests, and they're fabulous. They join in with both myself and our medical providers so that we really are able to streamline the services that a family may get. So even at your new patient appointment, we may do some testing just to get some snapshots of various things, including problem solving skills and adaptive skills, things like that, where we want to sort of give ourselves as much information about the child to help make those recommendations and to move on from that initial appointment. So they're fabulous and they support a lot of the things we do. Our psychology intervention team, we're lucky to have 2 licensed pediatric psychologists who provide intervention services. So we have Marielle Kennedy and Jeff Shadula. They're also part of the psychiatry and behavioral sciences group through Dell Med that I'm a part of. And they are both trained and focused on providing pediatric interventions for the types of things that developmental behavioral pediatrics tends to see. So a lot of that does include, and we'll get to it sort of broadly, some parent management training or some real structured evidence-based interventions for behavior management. So things like parent-child interaction therapy, and also interventions specific to children with autism like Ruby. And so that's our intervention team. They we refer to them in-house. And so those types of services and work with them are available to our entire sort of DBP patient population. Let's see. So our social work team has also grown. So we have Caroline Turner, who's been with us for a bit, and Anna Beavers, who's a little bit newer. And Caroline is really integral to a lot of our care coordination, community outreach. She keeps a fantastic pulse on the types of referrals that we are able to make, understanding what places actually have space, what wait lists look like, what types of providers are appropriate for individual patients that we have, just because we know that they, not one size fits all for even speech, OT, or ABA type referrals. Anna is a licensed clinical social worker, so she also provides some intervention services similar to our psychology intervention team. And so she is a fabulous addition to our team. She does individual work. She tends to also see kiddos at a slightly higher age range, which is fantastic as we're seeing a lot of our patients age into that school age or even older. And she is able to provide group-based interventions, as well as sort of a new area of executive functioning coaching. So for some of our kids that have diagnoses of, let's say, ADHD or have some organizational challenges, she's doing some of that as well. So we're super happy to have her. And let's see. I want to double check. I'm just going to sneak in. Okay, there's nothing in the chat yet. So we'll shift here. Our assessment services, like I said, they range. They can occur, in a new patient appointment. We can do a quick screening of cognitive functioning or problem solving, adaptive functioning. We often utilize rating scales, whether those are completed by parents or teachers or self-report for other older children and adolescents. And really, we try to sort of span the whole continuum of either administering screening measures or interpreting those that may have been delivered through the community, whether that's through the PCP or any kind of early childhood intervention group or schools. So we, provide or interpret and incorporate a whole host of evaluations and data, really. So specific to autism, I would say we often get information from the Ages and Stages questionnaire or the MCHAT that may have been provided by the PCP at one of the well child visits. The STAT is something that is a screening tool that can be provided in primary care or is sometimes utilized by ourselves in our appointments. It's I guess the best way to describe it for those who aren't familiar, it's a little bit of a mini ADOS in the sense that there's a lot of manipulatives and a lot of sort of unique social situations that are presented, play-based situations that are presented, and we're just sort of taking information about how the child reacted to those. The ones highlighted in green there are some of our rating scales that we love for parents and teachers to complete, so we have a variety of informants from different settings. And then toward the more diagnostic side of things, we do, of course, have the Autism Diagnostic Observation Schedule that we deliver quite often throughout the week, and for a whole range of ages and language levels. And then we also utilize quite frequently the Childhood Autism Rating Scale, which is a nice combination of parent report as well as behavioral observations. These are just a sample of some of the things we use in clinic or interpret in clinic, and some of the most commonly used tools, but certainly we utilize a lot of other things. Let's see. Okay, perfect. We'll get to those questions there. So that's just an overview. And this is just kind of a little bit of a deeper dive for each of these. So there's 2 different versions for the cards. It's a 15 item rating. And so really what we tend to do is utilize this as sort of a total score when we look at a lot of different areas of functioning, from language to sensory processing to relating to other people. All of those sort of come together to give us a sense of how likely that a child may meet criteria for autism spectrum disorder. This, as well as our ADOS, of course, which is this really fun, amazing tool. And those 2 are, it's important to note that they're tools. They're great, but they're always part of a broader evaluation. So no one score, no total score on an ADOS, no total score on a CARS is sort of a one-to-one diagnostic measure, but they certainly inform the broader picture, and that's something we like to highlight, and certainly something we like to really emphasize when training folks to use these tools is to sort of know the use, but also know the limitations of standardized testing. That's something that's exciting that we get to offer to the LEN trainees, and we do a deeper dive in that way with those trainees. The Mullen Scales of Early Learning is the developmental tool that we use a lot, especially to look at nonverbal problem solving. This looks like matching and puzzles and a lot of visual discrimination. And we really like to use this tool to get a sense of like I said, nonverbal problem solving. Many of our kids, especially our young ones, come in with some sort of speech delay or perhaps atypicality. And so we try our best to get a sense of where some of their underlying problem solving is outside of that speech delay. So we often use this tool, but we even see very frequently that there's kind of a pattern of challenges that our children with autism don't always perform, let's say, to the same degree that we might expect on certain items. So it's something that we're aware of, and we always interpret with caution, and certainly like to interpret that for families as an understanding of whether we think it's a fairly accurate estimate, or whether we think something like difficulties with receptive language or attention, or maybe some fixation on some of the items that are presented. If any of those seem to impact the overall performance, we absolutely write that in our results, as well as communicate that to the families. So it's something we're very aware of. Speaking broadly about assessment is that it's standardized testing has its limitations for everyone, but we certainly know that it can be even more limited in its application to neurodiverse individuals. So let's see. This model we have, our STAR model of early autism assessment, is something we're pretty excited about, mostly because it's been has had a big impact on reducing our wait lists, as well as doing so with equity. In terms of the research that we've done on this, is that whether our patients were Spanish speaking or speaking any other language other than English, they, as well as private insurance, non-private insurance, all of those who participated in this model of early autism assessment were equally accessible to increased access to care. And we found that our team-based approach allows us to really streamline these referrals and really increase how many new patients we get to see per week, and then also how long the children are on the wait list for. And this is a little graphic that we've created to show what goes on in the particular appointment from the assessment side, and then who's involved. So our core providers are the nurse practitioner, the developmental behavioral pediatrician, a psychologist or psychometrist, and then our social worker. And then those are sort of the top there. And then very intentionally, the bottom layer of those sort of has overlap between the various providers and what they can provide. And one of the things we highlight with this is that if any person from this team, any role from the team were to be missing, which happens sometimes, of course, we've been implementing this for several years now, and we don't always have every person present for various reasons. And so we are able to sort of flexibly shift and still provide the same appointment details, and everything is covered. So it works really well, and we think it's a pretty comprehensive appointment. That being said, part of the reason we are able to do this work so efficiently is sort of this iceberg that we have going on, which is that there is a lot that occurs prior to that formal assessment when the family is actually at the clinic with us. So there's a lot of work done by our fabulous triage team, our nurse coordinator, to make sure that the kiddos we see, in that consistent clinic are appropriate, and that we are able to look at all the data that may be already existing for that child. So records from early childhood intervention, developmental assessments, school-based evaluations, referrals from any other provider or specialist they have, including records from neurology or their primary care physician, speech or occupational therapy records. So there's a lot of work that goes into preparing to see these kids. And so we feel like we know quite a bit about them even when we walk in the room. And so I think that is sort of a hidden component of this. That it's definitely unique in terms of a service delivery. And so one of the things I'll highlight here is that we sort of have groups of kids that it doesn't necessarily change at all when they come to see us, but it does sort of inform what types of things we will do during those appointments. So a data kiddo is someone that has some existing evaluation data, like I mentioned, say an MCHAT, or some sort of developmental assessment prior to coming to see us. Our not a group is that this child really hasn't been seen by any other specialists, or maybe hasn't participated in a school-based evaluation. And for whatever reason, we may have really no testing on this child, or other than really at that point we have sort of the new patient paperwork and what the parent might be describing as their concerns. So sometimes those appointments are, we might do a little bit more evaluation during those. And it's just kind of helpful for us to know when we're walking into the visit. These are a little bit outdated at this point, but these were some of our preliminary outcomes, was looking at what was sort of a standard 18-month wait list to be seen in clinic, and really within Central Texas, one of the few places to go to have a specialty autism assessment was DBP, and that was an unfortunate wait list at that point. So at the, fairly sustainably, we've been able to keep this to, I would say, an average of about 4 months wait list. Sometimes it's a little longer, sometimes it's even a little bit shorter. So it really just kind of has been sustainable, I would say, over time. And then sort of the flip side of that is the number of new patients that we were able to see per month. Some of the expansions that we have is that we already are expanding with Dr. Serta, a Spanish-speaking comprehensive autism program, and we're exploring what this looks like for some of our older kids. Things are naturally a little bit more complex at that point. They tend to have some more history of either diagnoses when they're at that school age, or specialists that they've seen, or maybe even different evaluations that they've had from school. So we're exploring what that looks like to try to maintain as much efficiency as we can, but also provide that high level of care for that age. We have dabbled with collaborating with the the hearing center, so the ear, nose, and throat post cochlear implant recipients. Some of them are referred to us to look broadly at differences in communication that may be going on despite the context of that history of hearing loss and surgery. And then also we've talked about just sort of duplicating the model in order to continue to sort of meet the needs of the community. Let's see, this is just another graphic of sort of what happened starting from about March to August of 2019, and then those numbers fairly leveled out, and then with the addition of even more developmental behavioral pediatricians and just the general expansion of the team, we're continuing to try to meet the needs of the community for new patients. Let me double it before I shift again. I'll come back. Okay, perfect. So our intervention services is something pretty exciting. I think it's unique in terms of sometimes developmental behavioral pediatrics groups are sort of more that assessment and consultation model. We love that we have in-house providers to refer our families to for a whole host of different things. And each of these providers sort of has a niche, I would say, in terms of the type of work they might do or the type of referral that feels like the best fit for their area of expertise. Broadly, though, I would say, there's a lot of parent management training. So under that umbrella, we have the formalized, parent-child interaction therapy and Ruby intervention, both of which are really designed to help parents learn how to manage behavior in their kiddos. There's a lot of care coordination that goes on with our medical providers. So that's one of the benefits of being part of this interdisciplinary team and co-located in that way. It's nice to sort of have multiple eyes from the team and have that quick coordination if there's anything that's of concern, or as the medical providers this is just one example, as medical providers may manage a medication or start a medication for one of our patients, when they're also being seen by one of our psychologists, let's say on a weekly or bi-weekly basis, there's a lot of really great feedback that can come from that, as opposed to sometimes waiting to that next medication management follow-up. So that level of care is really great. Some of the other things that we are able to provide through our intervention psychologist is some quick brief interventions for things like feeding, toileting, sleep, and medication adherence. So those are also really nice to refer to in-house, and again, sort of keep that coordination of care and tracking progress. Let's see. I would say with the addition of Anna, which is fantastic, I think, and as I mentioned, we sort of she's able to expand our age range a little bit to work with those school age kiddos a little bit more. We're able to provide a little bit more of just general outpatient CBT, whether that's for anxiety or if there's a combination of anxiety and social skills happening on an individual basis. We can do exposures for selective mutism or even OCD. There's executive functioning coaching, and we have staff who are trained in the peer social skills group, and we've piloted one group of that, and would love to continue to do more of that. I think as anybody who does group work, especially social skills group work, would probably know that matching kids and schedules and things is a real logistical challenge. So I would say that's sort of the only barrier we have in terms of providing this, but we have the staff, the training, and the ability to provide that, and it's one of the things that we're really excited about as our kids age into that age range of sort of the teen and tween, and social skills are something that they really would benefit from getting specific training on. Let's see, even more. So we have a social skills boot camp that takes place a lot of times over the summer. We have post-diagnostic support through a brief group-based program called Autism 101. And then we are also a site for SIB shops, sibling support. Again, all of these kind of group-based interventions are sort of on a rolling basis. It's something we always have as an option, and we have these QR codes so parents can then just scan in the clinic and fill in a form that lets us know that they're interested in that. And then what we try to do on the back end is really coordinate schedules and kids, and then just kind of launch into those. So there are things that are kind of available on a rolling basis. And training, I would say, is a big part of what we've come to provide at DBP. And so the ACT Lend group is one way that we're able to do that. We have students from undergraduate programs and graduate programs from the University of Texas, some of which come from the Speech and Hearing Center with Dr. Jesse Franco. We have psychology interns, practicum students, and postdoctoral fellows that come through the Texas Child Study Center and the Psychiatry and Behavioral Sciences group that I'm a part of. We have medical residents that rotate through with Dr. Ravenscroft, Dr. Tran, Dr. Serta. And we also have psychiatry fellows that come in and do some observations of various clinical interventions. And then we even have some collaboration with students from Baylor. We are a site where we also provide, let's say, research opportunities for undergraduate doctoral theses, undergraduate theses, and then also doctoral dissertations. So we interface with a lot of groups, and I think we all really enjoy working with our trainees and our students. So we will only continue to expand that to our abilities. And one of the other things I mentioned there is our research. So we have our Improving Access to Collaborative Treatments research lab, and some of the major areas of interest that are consistent across all the different providers and researchers in our group is, of course, increasing equitable access to care, the novel service delivery models. Thanks to COVID, we've been able to sort of look at some of those service delivery models and how they translated to telehealth. The post-diagnostic support programs, we're really interested in, are they helpful? What does that look like? Are parents accessing the interventions that we hope that we recommend? We have a subgroup of those interested in supporting women and girls. We call it our swag team, which is really fun. And then there's also just sort of this general interest in the evaluation of the application of standardized assessment tools for the ASD population. So a lot of these are, interests and projects and areas that we research based off of our trainees and our students' interests. So I think, we really value that participation. Let's see. Speaking of, this is sort of some screenshots of our lab CV from about a year ago. So it certainly has expanded since, but the biggest thing I like to highlight from this is that we've highlighted all of the red that you see is our students. And so they are authoring quite a few things with us, and we really like for their work with us to be sort of a launching pad and an opportunity for them to take the lead on research. And so we've really been lucky to work with so many students in that way. Let's see here. Let me make sure. I'm jumping through things quite a bit. Perfect. I'll jump back to that. And then the referral process. I think that's something that I get emails about from colleagues, from various people, just to kind of know, what does it look like if we want someone to come be seen in DBP? It's fairly simple. It's a two-step process. It doesn't matter what order it goes in, but really we need a referral from the PCP to Developmental Behavioral Pediatrics. And that is just an insurance reason. It's okay if, for example, the teacher brings up the concern, or the early childhood interventionist is bringing up a concern and mentioning a referral to DBP. We just need it to come directly from the child's PCP, and that sort of information is communicated by our nurse coordinator as well. And then, of course, we need a copy of the new patient paperwork. So when those two pieces are received by our clinic, we are able to contact the families, give them a sense of what the wait looks like, and then also, really just triage them into the appropriate clinic. The development of these very, sort of specialized clinics that happen throughout the week is really kind of born out of this evidence that we see that it really does decrease wait lists. So we're constantly trying to develop things that that are sort of novel in the way that we deliver these evaluation services to continue to really make sure that everybody is getting in as quickly as possible. And one of those things is making this new patient paperwork easier. And so we've for a while now been working on an electronic copy of this. So easier to share with the families, and also potentially easier to complete, although it's a process. It's been something that we've had a lot of great help from our students and our research team, and it's something we hope again will even streamline services for families. Let's see, I have time for questions now, which is great. I wanted to leave quite a bit of time for questions, given that this was an overview. And so let's see. I can try to go through some of the chat here. And okay, so let's see. Yeah, absolutely. Advice for an 18-year-old who's graduated high school and wants to go to college. What is available to autistic young adults in Austin? So I would love for others to chime in as well. This is not necessarily an area of expertise for me. However, I do know in individual colleges in town, including like Austin Community College, they do have specific supports for those with a diagnosis. If that's an option. I know that there's also something I believe is still available, the college living experience, but I'm happy to have others chime in a little bit more.
I can share a little bit on that. And I will say too, is I relate to this parent's concern. I actually have a high school senior who's autistic and getting ready for college next year. So I've looked into this quite a bit as well. Depending on their level of support need, I know if they need help getting supports to be academically college ready, Austin Community College does have a good program called Pathways that is jointly done with Texas State University, so that you get developmental coursework and core coursework, and then if that is passed and they get a lot of supports, it transfers right over to Texas State. They also have specific neurodiversity support, social support programs there. UT has Longhorn Ties, which is social supports and also can help direct to other services on campus. Pretty much any college or university, I would suggest contacting their student disability services or accessibility program, which you can usually find on their websites, and contact them. The process of getting accommodations in college is a little different than when they're a student in high school, but they can help you walk through that process.
And I would just add that for students who may not feel like they want to go to college, but do want to further their education in more vocational areas, you definitely get connected with Texas Workforce Commission. And we have a program at TCDS called E4 Texas, which provides vocational education, but on the UT College campus. And the Texas Workforce Commission pays their tuition if they're eligible through that organization.
Great. So there's the next question I see in the chat says, are the social skills groups happening now? I know you said they happen on a rolling basis, and sorry, I missed the age ranges of those. Is there a cap to the group sizes?
Great question. So we don't have one actively going now. I think that again, that's not because we're not ready and willing. I think sometimes it's just become a little bit of a challenge to coordinate schedules. But I think the more the bigger the pool of students that we have or individuals in order to pull from and to match up for the groups, the better, so that we can kind of keep those going. And so the age ranges, so the particular intervention that we're delivering is the intervention out of UCLA called Peers. And so that age range is fairly specific to sort of that adolescent age range. I would say probably about 11, 12, 13 is sort of what we look at. We, however, realize that, and this is something that we see, is that even younger, our kiddos are really needing that social support. And so we've talked about and definitely are interested in perhaps modifying some of that to capture that age range as well. The cap to the group size, it's kind of flexible, I would say. I don't think we typically like to do more than like 6 or so, but we are able to also deliver it with telehealth. So again, we want to be able to do both, because some people have a preference. Some of our patients don't enjoy the Zoom option, and then other families like that because of course it's a little more accessible without the travel involved. And so we're trying to really bolster that, and I think it's just one of those things that just depending on the interest and sort of the organizational side of things. So, and then and your comment there about Spectrum Social, yeah, very aware of that fabulous group there. It's one of the best groups in town for it. I know that they're private pay, so one of the things we really worked on is trying to make the our group accessible through perhaps even billing or getting grant funding for social skills groups through our clinic to make that even more accessible to different families. And so, yes, I'm glad that people know about that group as well. We definitely make referrals to that, but we just also feel like there's no shortage of need for social skills groups to happen. Perfect.
Okay. Let's see, the next question down, I see that my chat just jumped on me too. So hang on a sec. Where can I find the social work and community outreach resources you shared on your PowerPoint?
Well, let's see. There's a couple ways to do that. So we do have those in clinic, but I want to double check and see. I don't think they're on our formal Dell Children's website. It's a little tricky for the content on that, and it's kind of hard to update that regularly. So whatever we have on that website is typically something that we think can last there for a while, whereas these groups that we have where we might have information about different dates and what's going on and contact information. What I think would be a great idea is if I were to follow up either by email through the whole group to there is a newsletter that's sent out by Caroline Turner, our social worker, who regularly kind of blasts out things that are going on. And so knowing when those particular community resources and outreach resources are happening. So if that would be of interest, I think that might be the best way to sort of have that information in an ongoing fashion. So anyone can sign up for the DBP newsletter for sure.
Thank you. Also, yes, in the chat, Angela Standridge, who runs the Texas Technology Access Program at TCDS, posted about resources that are also available to check out, and she posted a link there, and that is a really good one to check out, especially around short-term device loans and pretty much everything to do with AAC and iPad AAC devices. I highly recommend, if that's a support need that you have, to take a look at that.
Yeah, thank you so much for sharing that. That is something we see quite a bit. So we do actually kind of guide parents at times about exploring AAC devices. We do refer I guess the one go-to we have other than this, which sounds fantastic, is that there is sort of an assessment process that we can refer to through Dell Children's. However, this is so nice to have, because sometimes that wait list does get long, and so multiple options is great. And either, you know, a lot of times we see families who may have tried one thing, right, and maybe that's not working out, or their child wasn't interested in it. And so that's so helpful to know about that. Thank you. I'm gonna make sure I take a little screenshot of that and share it with the crew so that we all know to refer to that service.
I had a quick
Great.
question for you. I was wondering if you had any numbers on how many families you're typically helping at any given time. How many children are in?
I wanted to. Oh, I was going this. Some of the numbers that I know are, you know, I think we have at least 400 new patient appointments a year, something like that. And that's probably just maybe one provider plus that team-based eval. So that you can kind of multiply by all of our other providers now. And then I would say a good majority of our families have at least yearly follow-ups, just to check in and make sure progress is happening, and really, you know, help continue to track as they go through different stages and make, you know, recommendations for school and various other intervention decision making. And so, gosh, it would be such a like an exponential web of things, but I would say, yeah, in the hundreds to thousands probably. And then that's not even, I guess, you know, I'm thinking just, and then I think about the intervention providers and some of the other things that we have going on. So yeah, I think that if we kind of look at how many new patients happen across the medical providers, and then there's typically some version of the downstream referral, either within DBP or out into the community for further resources.
Cool. And kind of building on that, I was wondering too, is most of your reach kind of in Central Texas, or do you have patients and families coming from other parts of the state?
Oh, we do. And so yeah, we have a unique number coming from sort of the College Station, Bryan area still. And certainly with our expansion down to Buda, I think we're seeing more and more families who actually live in San Antonio. I know at it's pretty far reaching. So it's I would say it's generally Central Texas, but in sort of the broadest terms of that. We have had some families drive in all the way from more like the coast or and things. So I think sometimes they in those situations, it may be for a second opinion, and that may not be like, they may not have been their first stop along the way, let's say, but sometimes we will see that.
Thank you. We have a question in the chat. How would we learn about opportunities to get involved and support the Impact Lab?
Yeah, that's a great question. We do have a monthly kind of all hands meeting that is really open to whoever. I mean, we have students that are coming from Texas A&M that come in. I should have put that one on there too, but a lot of times we just have people reach out if they're at all interested in research. We have a fairly robust set of RAs, so anywhere between 6 to 10 each semester we have of research assistants that really move things along and help sort of continue to build this clinic database that we have, or drive their own projects. So a lot of times we encourage them to participate in the interprofessional health showcase that goes on at UT. I think that's through the School of Pharmacy or Nursing, one of the two. And each year we really try to get them to do that, and then maybe launch that into some more sort of national poster presentations or things. So certainly you can reach out to myself, and Dr. Jeff Shadula is part of the research as well, as sort of a co-leader of the lab. So really, I think what we tend to do is meet in that big all hands meeting, and then people sort of have their own little separate meetings depending on what projects they're working on, as sort of little subcommittees or subgroups based off of interest. So happy to share my contact information, so you can just directly message me and we can set that up. So I'll put my email in here, and this is for anyone who may have follow-up questions.
Great.
Okay.
Does anyone else have any questions? Please feel free to drop them in the chat or in the Q&A, and I can read those out. I also want to remind everyone, if you could please complete the survey I put in the chat a minute ago. That'll help us with our evaluation on this end afterwards. Oh, Meredith, that actually went to, here, let me drop that. That just went to the host.
Oh, I see, just the host and panel.
That's okay. Hang on one
Thank
second.
you. And I wanted to look, there was another one, AAC assessment training. Oh, coming up October 5th. Oh, wow. Wonderful.
Oh, that's great.
Let me click on these. So.
Well, if there aren't any other questions, I want to just thank Dr. Brinster again for joining us today and for sharing about your program there. It's I know that I've had some contacts with you through the LEN program, and also Caroline Turner was my supervisor when I was getting my master's of social work too. So it's really fantastic, and the work you're doing I think is so important for Central Texas and the families that live
thank
here.
you. I love how connected people are, and I think this, this whole consortium is a really, really fantastic way to sort of just, learn from each other and know what's out there. I think it's so wonderful to have this connection from all these different groups. So thank you for having me.
Great, thank you. Okay. Goodbye.
All right, thank you.